Being a therapist, I know the work doesn't end when the session does. Notes, billing, scheduling, insurance follow-ups, it can all eat into your nights. That's why Katie and I use Simple Practice. Start with a 7-day free trial, then get 50% off your first 3 months. Just go to simplepractice.com.
This episode is sponsored by The Receptionist, a sign-in app company. The Receptionist for iPad is a HIPAA-ready digital check-in system that allows you to easily check in clients and take your time back. Learn more by visiting thereceptionist.com/MTSG and get your first month free.
You're listening to the Modern Therapist Survival Guide, where therapists live, breathe, and practice as human beings. To support you as a whole person and a therapist, here are your hosts, Curt and Katie Vernoy.
Welcome back, Modern Therapists. This is Modern Therapist Survival Guide. I'm Curt with Katie Vernoy, and this is the podcast for therapists about the things that go on in our world, the ways that we can help our clients. And we've all told our clients to trust their gut, but what happens when that gut is constantly sending out error messages? As therapists, we are great at helping people to digest their trauma, but we're often less than prepared when digestion is actually the problem itself. So we are joined today by Dr. Ali Navidi to talk about the messy, often literally messy intersection of GI issues and mental health. And we are very grateful to have you here. I promise I will not continue to make these jokes throughout the episode.
Curt, I think it's a wonderful start to this podcast today. Because it actually got me thinking. I'm like, yeah, that is a common saying. And the types of disorders that I'm frequently treating are literally ones where I need to teach patients not to trust their gut.
Oh,
So
interesting.
It's perfect.
Oh, interesting.
Yeah.
I'm so excited to jump into this. This is something that's near and dear to my heart. But before we get started, I'd love to ask you the question that we ask all of our guests, which is, who are you and what are you putting out into the world?
So I am, in a concrete way, like I'm a clinical psychologist in the DC metro area, and I've had a practice, a solo practice for about 14 years. And what I'm putting out in the world is kind of a labor of love of starting so long story short, I developed a specialty in working with patients with GI disorders. And what I'm wanting to put out into the world is that you don't just have to live with it. I think that's kind of the core message of patients with irritable bowel syndrome, patients with chronic nausea, disorders like functional dyspepsia, things like that. Often they are given the message that, okay, we've done what we can. It's not going to kill you. Kind of just live with it. And want to put out there that this is not true, that there are very effective empirically based treatments available for these patients that really work and they help a lot.
So maybe starting with kind of the building blocks of this, I've often heard that the gut is kind of the second brain or the little brain compared to our talking big brain. Can you maybe start by breaking down that gut-brain axis in a way that therapists can understand how that might apply to their clinical work?
Yeah, so I like to keep it simple. And so the explanation I like to give about the gut-brain axis is essentially the same explanation that I would give to a patient. I don't think there's a lot of value in going deep into the neurotransmitters, into the different nerve connections. And I think if we just keep it simple and let people know that there is this thing called the gut-brain axis, and it means that there's a special relationship between our brain and our little brain in the gut. And the reason we say little brain in the gut is because there is a little nervous system in there. And so they are always communicating with each other. And that means that the gut is influencing the brain and that the brain is influencing the gut. And so what happens in each affects the other. And that's a really important starting point. And, you could get into the vagus nerve and the central nervous system and the enteric nervous system. But essentially, people need to understand that communication is happening, and it's happening all the time.
What does it look like, that communication?
Well, yeah, I think some of it is just it's kind of well understood, right? We all know my son, for example, we all know people in life who get hangry, right? And he was a perfect example, just unreasonably angry. And then literally right after he's done eating, a wonderful, kind person. And the shift is just so quick and so powerful. And that's just a simple example of how the gut affects the brain. And we know that the brain affects the gut also because we can think of something and lose our appetite, or we could think of something else and start to feel hungry. Who hasn't been engaged working on something intensely, and then right when they're done, they're like, oh, wait, it's lunchtime. And then suddenly they start feeling hungry. They didn't feel it before, but right when they thought to themselves, okay, it's lunchtime, now they're hungry. And so these are just simple examples of how the brain can affect the gut and how the gut can affect the brain.
I am maybe starting this with, I don't know that I've had any clients ever come into me identifying, hey, I have chronic GI issues as their primary reason for mental health treatment. And I'm wondering what kinds of presentations do people usually show up in, maybe kind of the general therapist's office, that would warrant the therapist to screen, hey, do you have medical history that needs to be checked out? How does this normally show up?
I love that question because I think as therapists, we are in a great position to catch a lot of these problems and to steer people in the right direction. But I think we're not trained to ask. It's not part of our general training. So I can make it really easy. Like 4 main groups are going to have a much higher percentage of these problems. And these problems are called disorders of gut-brain interaction. They include irritable bowel syndrome. They include about 20 other disorders that can occur in the GI system. But they're all disorders that there's no structural cause. The cause isn't because of inflammation. It's not because of an ulcer. It's not because of a tumor. It's they're going to check it out and they're not going to see a structural cause. The cause is more process of how the gut and the brain are communicating with each other. So there are 4 groups that are going to have a higher percentage. Right off the bat, patients with anxiety disorders. They're much more likely to have GI issues. Patients with a history of trauma, much higher percentage of GI issues. Patients that are on the spectrum, also much higher percentage. And then any patients that have or currently do have an eating disorder, they also have a much higher percentage. So if you have patients in those categories, which I don't see how any of us don't, just simply asking, how are things going with you in terms of your GI system, in terms of upper GI, in terms of lower GI, how are things going? And then if they're saying that there's some problems, asking if they've gotten it checked out. Because that's always the step, right? I don't want to start treating someone for IBS until we get a medical professional confirming that it actually is IBS.
Being a fellow therapist, I know the work doesn't end when the session does. The notes, the scheduling, the billing, the insurance follow-ups, all of that admin can quietly take over your nights and weekends.
And we've both seen how the right systems can really change what private practice feels like. When we're talking with therapists who are overwhelmed, one of the biggest pain points is trying to hold too many disconnected pieces together.
That's why we want to share Simple Practice. Simple Practice is an all-in-one EHR that is HIPAA compliant, high trust certified, and built specifically for therapists.
Simple Practice is designed for the real-life complexity of private practice, helping with everyday admin that can pile up between sessions.
My favorite part? the all-in-one integration. Notes, billing, telehealth scheduling, and client communications are all connected in one spot, so I'm not bouncing around between separate systems.
And their AI scribe note taker can help make documentation more thorough and much faster, so you can spend less time catching up on notes and more time focused on your clients and your life outside of work.
Plus, if you're starting out or growing your practice, Simple Practice also offers credentialing support, which can take a big headache out of insurance enrollment.
If you're ready to simplify the business side of your practice, now is the perfect time to try Simple Practice.
Start with a 7-day free trial, then get 50% off your first 3 months.
Just go to simplepractice.com to claim the offer. Again, that's simplepractice.com. It seems like it would be fairly murky. I'm thinking through how process can lead to more functional disorders in the GI system, and somebody that chronically has IBS might eventually, develop gastritis or something. Obviously, we're not doctors. We're not talking about it in that way, but it seems like it might be fairly murky. How do you make sure that you're staying within scope when you're looking at this? I hear that have a doctor check it out, but how do you make sure that you're staying within scope and keeping the communication open with the GI specialist?
Well, I think you just answered the question, right? That is, not just me, but also for all the therapists working in the clinic. That is part of what we teach them to do. You got to talk to the providers, and often you need to talk to them more than once. Because here's a common example. A gastroenterologist, because we get a lot of referrals from gastroenterologists. Gastroenterologist diagnoses someone with IBS. They come in, we talk to them. By like the third session, they're comfortable enough with us to say, you know what? I'm not sure it's really IBS because, I'm having this pain and this and that. And they're saying, I think it might be something else. I think they missed it. I think they missed what it really is. So then what do we do? Well, you don't want to just sit there and try to help them figure it out yourself, because now you've just walked outside of scope, right? And potentially putting your patient in danger. So the move for me is I want to talk to that gastroenterologist and I want to talk about the patient's concerns. Now, sometimes you'll get, okay, maybe we need to get them in for more testing. But sometimes what you get is, well, we have tested the hell out of this patient. They've had an endoscopy every year for the last 4 years, and every year we see the same thing. And this is their anxiety showing up. This is their health anxiety. And that's good for me to know, because now I have another target for treatment. And then I come back to the patient and I can convey the certainty that the gastroenterologist had about their condition as a kind of a lever to help them with that anxiety, to give them a reason to work on it as a problem rather than, okay, I just need to let my mind run wild about what these symptoms could mean.
Or give up.
Yeah, or give up.
So from there, I'm assuming a lot of the treatment ends up dealing with anxiety, dealing with this. I don't know if this fits into the episode, but dealing with hypochondriasis kinds of issues. Is that kind of where you end up going with clients like this?
That's half of it. So you can think of it as kind of like primary and secondary. And this is the thing I think a lot of people don't realize. So this category of disorders is directly treatable with behavioral health techniques. What that means is that we're not just treating the secondary anxiety. We're not treating the difficulty coping. We're not treating the problem accepting the disorder. We can actually treat the disorder. And the data shows extremely good results, meaning over the last 40 years, they've done hundreds of studies looking at specific kinds of CBT, not, plain vanilla CBT, but specific kinds of CBT and specific applications of clinical hypnosis. and looked at the outcomes. And the outcomes are very good. Like just looking at certain protocols for clinical hypnosis, you get 70 to 80% of the patients reaching their treatment goals, meaning not just reduction in anxiety, but reduction, let's say it's IBS, reduction in, diarrhea, reduction in constipation, reduction in bloating, in pain, in discomfort. So those are primary effects. We're not just secondary effects like health anxiety, hypochondriasis, coping, acceptance, things like that we still might work on, but we can also work on a primary level.
So this is really exciting because I think there's a lot of frustration that I'll just say I've had as a clinician when I see my clients going through the health process and they continue to come back from their doctors. There's my medical tests are normal, this is horrible, and there's so much going on there, and potentially things are being missed. And so I do want to honor that doctors are not perfect. They're going to miss stuff. We don't want to doubt someone's experience. And it sounds like being able to address these disorders of gut-brain interaction directly can be very effective to help clear up the picture. So maybe that's not being missed, but maybe something else is, but it's all being muddied because when you've got you sent us something and it's a DGBI, disorders of gut-brain interaction. When you have a DGBI, that is going to be all-consuming at times because our gut is fairly consuming. So how do you conceptualize what the disorder is, how you develop a treatment plan? Like, can you talk us through what that looks like? Because to me, this is very exciting. I really, I might be attending a training soon. So please fill me in. What do we got here?
Well, to your first point, what you were saying at first about muddying the water, I can give you a great example. So there's another class of disorders called inflammatory bowel disease. So that's Crohn's and colitis.
Mm-hmm.
And these are disorders where there's actually inflammation, there's strictures, there's damage in the intestine.
Gastritis, esophagitis, like there's a lot of things that are actually inflammation.
Yeah, there's real things happening in terms of autoimmune problems and the consequences of that. For IBD patients, this is not IBS, this is IBD.
Mm-hmm.
And so for those patients, what can often happen is they can develop a disorder of gut-brain interaction on top of the structural issues. So talk about things getting muddy.
Sure.
How do we pull that apart? Because they're going to have pain as part of the IBD. They might have diarrhea as part of the IBD. Or is it coming from the DGBI? One of the ways we can tell is if we look at blood tests, if the blood tests are clear that their medication is suppressing the autoimmune response, but they're still having symptoms, we can start to suspect, okay, maybe there's an overlay happening here. And then treating that overlay is actually going to do a lot for them because now when their blood tests are clear, they're actually going to have no symptoms versus they were having symptoms despite clear blood tests, right? So that's an example of that.
Your time is valuable. Whether you're hyper-focused on admin tasks like billing or simply trying to make a cup of coffee between appointments, constant interruptions can derail your entire day.
This episode is sponsored by The Receptionist, a sign-in app company. The Receptionist for iPad is a HIPAA-ready digital check-in system that eliminates the need to walk back and forth from your office to the waiting room to see if your next appointment has arrived. Clients and patients can securely check in for their appointments, and you'll be immediately notified by text, email, or your preferred channel. Break free from interruptions and make the most of your time.
Start a 14-day free trial of The Receptionist for iPad by going to thereceptionist.com/MTSG. Make sure to start your trial with that link, and you'll also get your first month free if you decide to sign up.
How do DGBIs work? Like, what are we looking at? And then as we go along, how do you create a treatment plan, and what does treatment actually look like?
So again, I'm going to give kind of the version I would explain to a patient.
Thank you.
Yeah. And it's very straightforward. I think as therapists, you're going to get it like the minute the words come out of my mouth. And so essentially, we need to understand the gut-brain axis, right? And we already talked about that. And then there's essentially three variables to talk about. Hypervigilance, which I think we all know well, catastrophizing, and then there's something new probably for most therapists is this idea of visceral hypersensitivity. So let me lay out the model, so to speak. So what often happens, and it can happen as a result of trauma, and when I say trauma in this context, I'm meaning trauma to the gut. So as an example, there's something called post-infectious IBS. That's where you get a real infection. It might be like MRSA or C. diff or just food poisoning or something that causes some kind of trauma. The infection passes, the trauma passes, but the symptoms don't all stop. And what happens is the brain, at usually an unconscious level, has developed hypervigilance about the gut. So now it's always anxiously scanning for problems. And usually there's a certain part of the gut that they like lock in on, probably the part of the gut where they had problems. And then if they notice anything is wrong, they start catastrophizing. Oh my gosh, like what's going to happen? Am I going to get nauseous again? Am I going to throw up? And then through the gut-brain axis, all that anxiety and stress actually starts to create symptoms. So it's this self-fulfilling prophecy. And if that were all, it would be rough. But then there's something called visceral hypersensitivity. And what that is when the brain chronically perceives danger in an area of the body, what it ends up doing is taking the sensations from that part of the body, amplifying them, and then distorting them. So what is, let's say, a full stomach after eating is perceived as painful, uncomfortable, and it can be at a very intense level to the point where patients are going to the ER because of that pain. And there's actually nothing wrong at all. It's just that the brain is amplifying and distorting that signal. And it's feeding it into a hypervigilant, catastrophizing brain that then sends even more anxiety down, which creates even more symptoms. So you get this loop that's always feeding itself. So then we treat it by targeting those variables. The CBT is for the hypervigilance and catastrophizing. The clinical hypnosis actually has been shown to directly reduce that visceral hypersensitivity. So think of it as like turning the dial down on the volume of the sensations and then kind of removing that distortion effect. So that's like kind of the basic model we want to start explaining to patients. And of course, with these disorders, there's a tremendous amount of avoidance.
That was going to be the question that I popped in there is, what do those early conversations sound like? Because I'm guessing that a lot of those patients have developed even a mistrust of a lot of healthcare field because they are feeling this pain, but going into the doctors, they're not seeing any kinds of results that are validating this.
Yeah. And I think that's a really common issue to deal with for people because they've been given this like sometimes implicit message that this is all in your head, right? And we want to make sure that people understand the pain from these disorders is very, very real. And the "it's all in your head" comment is a tricky one because all pain is in your head. If we didn't have a head, if we didn't have a brain, we couldn't have pain. So all pain is in your head, but more importantly, the pain is very real. It's as real as any pain that anyone experiences. And the symptoms are very real too. The diarrhea, the constipation, potentially nausea, vomiting, things like that. Bloating, often there's a lot of bloating happening, which is incredibly uncomfortable. So you have to balance that, because you also don't want people to get lost in the search for, well, then there must be something physically wrong. And often people, they delay getting the right help because they want that second, that third, that fourth, that fifth opinion, which leads them to bounce around the medical system for years before they get the right treatment.
How do you get folks to buy in? Because it feels so real, and you were saying it is real, but it feels like there's something structurally wrong to them. Doctors are
Yeah.
saying everything is fine or that they've treated the thing that was wrong. How do you get buy-in? What are some of the early wins that can help with moving forward quickly? Because it feels like this is a group that has a huge level of mistrust, like you just described. And
Yeah.
all of this, kind of even if it's physical, trauma to the gut, there's also medical trauma, there's potentially trauma in life. Like there's going to be a lot of these things that are continuing to exacerbate those symptoms. And so how do you get some early wins? How do you get this buy-in? Because I feel like this is tough.
It is. I think it's a mixture. Each person needs something different. Some people, when they learn about the depth of the research about these disorders, that kind of helps. Some people, when you hear them describe the model that I just described, that can help. Some people, when you go through their history carefully and you see that when they've had flares in their system, in their symptoms, it often corresponds to big things happening in their life. Big, stress, big difficulty. I think for each person, it's different. Sometimes it's trust in the doctor. Sometimes they just move forward and they're often a little skeptical,
I can
and,
imagine.
and it just is.
Yeah.
And then after they've had, let's say, their first or second hypnosis session, and they're like, "Oh, damn, that really feels different." Or their first experience where they can go from, having a 7 out of 8 pain to a 2 within 15, 20 minutes. And they're like, wow. And then you ask them, could that have occurred if there was something structurally wrong? And they're like, no, because we've just right now been working with your brain. And so through your brain, we're able to reduce that pain. And the only way we could have done that is if the disorder was a disorder of gut brain interaction, right? So sometimes they just have to kind of hold that skepticism and move forward in the treatment a little bit, because it's not a long treatment. Often, often we're starting to see results by like session 3 or 4, and often treatment is done by, session 10 to 12. So we're not talking about, treating, major depressive disorder or trauma or something like that. And that's actually, as a therapist, part of the reason why it's really satisfying to treat these disorders. Because what often happens is, let's say you treat an IBS patient, and that might take about 3 months. But then there's a lot of rapport, there's a lot of therapeutic momentum, and you can go ahead and treat their anxiety disorder or treat their trauma. And there's already this great working relationship. They already kind of know about CBT already. They know about clinical hypnosis, and you can use those modalities to now help them with their other problems.
I have a question that's kind of about scope here, but it also, in some of the information you sent over to us, is talking about the role that diet plays in the early stages of treatment. And so I'm wondering about how much do you get into the foods that people eat and the recommendations that you make, and being able to talk about how this makes sense as part of their treatment.
I personally don't I try not to talk a lot about diet. I I want people, if they want to go that route, to work with a GI focused dietitian. They're out there, they're often, they're really good at what they do, they know what they're doing. But what I see is often, these patients, let's say with IBS, they go to their gastroenterologist. They say, "Oh, you've got IBS," and they say, "Well, you might want to try this diet." And they hand them like a worn out sheet about the FODMAP. It's been like,
The low FODMAP diet or this diet
yes,
or that diet. Like it's
yes,
crazy. And they're so unhelpful, those little sheets.
yes, yes. Because these are, first off, they're complex because these are elimination diets, and there's certain orders that you do it in, and like then how do you pull back from the elimination? Because I've seen many patients that have been told about the FODMAP diet, but they think okay, that means I just keep avoiding FODMAP foods for the rest of my life. But
Mhm.
that's not the case with these diets. They need to eliminate and then reintroduce systematically in order to figure out which of the FODMAP foods are the most, troublesome and blah, blah, blah. And so you get these patients that end up developing ARFID, so avoidant restrictive food intake disorder, because of, basically bad information about these diets.
I think there's probably out of all of our scopes, but I think I need to find a medical doctor to talk about this too. But there's a lot of conversations about the microbiome and how
Mm,
the things that we eat will impact that, and just kind of bringing it back to kind of what your scope is. I know when I I I try things myself or I talk about it with other folks that there's when you're introducing fiber-rich foods or you're introducing foods that are different than your day-to-day, some of that pain, some of that stuff can be reintroduced. I'm thinking a low FODMAP diet's gonna just bring down any inflammation or any kind of discomfort in your stomach, so maybe that helps just because of that, if it's a DGBI. But I think there's this element of huge amounts of information around,
mm,
especially microbiome lately, but there's a huge amount.
yeah.
So we're fighting against a lot of those things. And so I'm curious, how do you approach conversations about what's happening in the popular culture around food and diet
Right.
and how that might interact with somebody that has a DGBI? And then also, what are things that therapists should be aware of if they're not necessarily treating those things so that they can support getting them to the right provider? Because it feels like these conversations get huge. So maybe that's too broad of a question, but we're getting low on time. So answer what you will there.
Yeah, yeah. So so uh, so basically, there's a ton of information out there. There's a ton of misinformation out there. There's a ton of claims about things and over claiming things. I think some things to be aware of is that, we've got the microbiome, and this is a real thing. This is something that has been studied seriously for a long time. It affects our digestion, it affects our mental health. We're still figuring it out. So we don't really completely understand what's happening and why and how to alter it. We've got some theories, we've got some people trying things out, but it's all very new. The science isn't super well established yet. So people are going to play around with probiotics, they're going to play around with diet changes. They're going to look at things like SIBO. And I think I always have trouble with it. It's like small intestinal bacterial overgrowth. And that gets even more confusing because there's a lot of overlap between patients with IBS and SIBO. And so I've seen patients overly focus on the SIBO aspect of it, spend years on different naturopathic protocols, antibiotic regimens, trying to clear up the SIBO that just keeps coming back. And then one course of brain gut therapy helps like 70 to 80% of the problem because they were hyper fixated on dealing with these bacteria when a big part of the problem was the brain gut connection and not necessarily the SIBO. So it's a very complicated subject. I think people can often get lost in the weeds looking at their microbiome. And I think a lot of time we just don't understand it well enough for there to be anyone who gives you a clear answer and seems super, super confident about like, oh, you got to eat this kind of starch, I would be a little suspicious of.
Exactly. So for therapists who don't specialize in GI work, what do we need to know?
I think the key thing is that a lot of our patients are suffering from these disorders, and I think they've often just accepted it. And that's probably a lot of that has come from the medical institutions that just don't either two things like, and I'm not trying to pick on the doctors, the physicians. Often they don't know that these treatments are available, or if they know, they can't find providers because there's only like about 600 in the world that are properly trained, which is sad, which is why, we didn't talk too much about this, which is why I opened the bigger practice, GI psychology, because that was basically the idea is we want to make this treatment more available to people.
Where can people find out more about you and your work?
Well, perfect segue. So about 5 years ago, mostly through frustration with not having other providers out there who are properly trained in this, I started a practice called GI psychology, and it happened to coincide like directly with COVID hitting. So we were going to have maybe more of an in-person practice in the DC metro area, but so why are we paying for space that we're not using? So we decided to go virtual, and then we've kind of grown it from there. And so now we see patients in all 50 states. It's just gipsychology.com. We've got a very high level of training that we put our therapist. So basically when we hire, we look for therapists with some health psych background, and then and that already are experienced and know how to do therapy. And then we put them through about 6 to 9 months of a very structured internal university where they're getting tons of supervision, support, and they're going through a lot of didactic material as well. So gipsychology.com if you're looking for me.
And we will include a link to that in our show notes over at mtsgpodcast.com. Follow us on our social media, join our Facebook group, the Modern Therapist Group, to continue on with this and other conversations. We're on Substack and LinkedIn. And until next time, I'm Curt Widhelm with Katie Bernoy and Dr. Ali Navidi.
Private practice has enough built-in complexity. Simple Practice brings notes, billing, scheduling, telehealth, insurance, and client communication into one place. Start with a 7-day free trial, then get 50% off your first 3 months. Just go to simplepractice.com.
With the receptionist for iPad, there's no more walking back and forth to check the waiting room for your next appointment. Receive an instant notification that your next client has arrived, securely and privately. Visit thereceptionist.com/MTSG and get your first month free.
Thank you for listening to the Modern Therapist Survival Guide. Learn more about who we are and what we do at mtsgpodcast.com. You can also join us on Facebook and Twitter. And please don't forget to subscribe so you don't miss any of our episodes.